So next we have Dr. Rawan AlRashed. So Dr. AlRashed is our full year fellow. She'll be with us here. She comes from Saudi Arabia and she's a pediatric trained emergency medicine specialist. So she's going to be talking to us about the paper, The Diagnostic Accuracy and Prognostic Significance of PoCUS for Traumatic Cervical Spine in the Emergency Care Setting, a comparison of clinical outcomes between PoCUS and CT on a cohort of 284 cases, and review the literature.
Okay, thank you, Dr. Mahdi, for this introduction. So starting without delay, hello, everyone. So I was inspired for this articles or this paper by one case that we saw in the emergency. He was a 15 years old boy who had a motorcycle accident. He was received from another hospital on already C-collar and intubated due to his glasgomuscular deterioration. His arrival vitals to the emergency department, it was a heart rate of 115, blood pressure of 124/60, and SpO2 of 94. It's almost stable, acceptable vital signs for a trauma patient, aside from this slight tachycardia. So the ATLS protocol was initiated and the primary survey and secondary survey went through for these patients. The EFAS was negative, and we all know the value of the EFAS in diagnosing patients, especially the importance of the EFAS in mostly unstable patients, how it can guide the management after that on going to the OR and adding, if there is any craniotomy is going to be done, adding a laparotomy to that patient. So this patient, anyway, he was stable and the EFAS was negative, so he was planned for a CT brain and cervical spine because the glasgomuscular was deteriorating on arrival to the ED. So I had a question in my mind, would there is going to be any role of PoCUS in the cervical spine assessment, especially we are facing most of the time difficulties in a patient who are more of a low risk and stable patient to clear their cervical spine easily. I mean, we are facing it more in pediatrics age group comparable to the adults. I know that there is multiple clinical rules have been applied to help in the clearance of the cervical spine, like the Nexus criteria and the Canadian C-spine rule with a different sensitivity and specificity. So the Nexus criteria, the sensitivity for this is reaching like almost between the 80 to 100% and helping to clear the spine for a patient. And after that, adding to that a clinical examination. And the Canadian C-spine rule is having higher sensitivity in comparison, which is reaching about 90 to 100. Unfortunately, both of these rules are not applicable highly in pediatrics because it was not included in the retrospective and prospective validation. So if you had these rules negative, after that, you will augment your studies with possible plain radiography for the patients, which is carrying almost sensitivity of detecting spinal cord injury of 37 to 64. And the gold standard for sure is going to be the CT, which is having higher sensitivity of 90 to 100. In the risk of getting the patients to be exposed to ionizing radiation. So the question is always, is there any additional tools that can be augmented with these clinical prediction rules to help diagnosing these patients? So it will be an additional points instead of going further to the CT scan. And I think it's going to be very highly applicable if it is going to be possible in pediatric patients, especially with the Nexus criteria included only 2.5% of their population are pediatrics, and the Canadian completely excluded them. There are other rules have been suggested, but until now, none of them is prospectively validated. They tried just to combine the Nexus and the Canadian C-spine rule, including the high-risk criteria for pediatric patients to have cervical spine injuries like a Down patients, Klippel-Feil syndrome, whoever is having a spinal abnormalities. So most of the time, in a pediatric settings, we are depending on all of these collectively, plus the clinical assessment, history, physical exam, and then trying to examine the patient and clear the spine, plus the plain films, most of the time as an initial tool, which is age dependent. So if the child is less than 8 years, the sensitivity of the plain film is going to be low, like almost in the 60 to 70%, comparable to the older age group, which can reach to the 90s. And for sure, always the CT is the rule, but there is a risk of ionizing radiation. So the question is always, can we utilize the point of care ultrasound to add to our assessment and help diagnose the patients, or at least clear the C-spine in a low-risk patients? This study was mainly dependent on a high-risk patient, so they tried to see the diagnostic accuracy and the prognostic significance of PoCUS in traumatic cervical spine injury, comparing it to the gold standard, which is the CT scan. So their objective was just to compare the, as we said, the ultrasound to the CT in diagnosing traumatic cervical spine injuries. To start their study, they have recruited patients from July 2017 until March 2020 in a prospective. It was including almost 284 patients. And the inclusion criteria for their patients was any patient who was requiring CT scan, and their indication for CT was a patient who was presenting with loss of consciousness, focal neurological deficits, patient who's having multiple severe traumas, or who's having Glasgow scale of less than 12, patients who's having any signs of symptoms of spinal injuries like spinal pain on history, or spinal tenderness on examination, stepping on examination, or also the patient had an abnormal radiograph. So any of these findings, it was suggested to do CT scan for the patients. Accordingly, they included these patients on their study. For sure, they had to take an informed consent for the patients, and they excluded any patient who had a previous cervical spine abnormalities. So like any patient who's having spondylitis before, if the patient is having rheumatological disorders, the patient is having patient who's having spinal tuberculosis, any abnormalities previously or spinal surgeries will be excluded from their study. So the plan was to do the PoCUS point of care ultrasound before the patient is proceeding to the CT. The point of care ultrasound was done by a radiologist, was not done by an emergency physician, and the same radiologist did the CT and interpreted the CT results. So there is a bit difficult in this. The side part from this, the collection of the data was done by another researcher who collected the clinical demographic of the patient, clinical presentations, and the outcomes for the patient, plus the ultrasound. And the CT results were kept until the end after he collected all of these data. So it's not a completely blind study. So the ultrasound technique for taking the image, they utilized a linear probe with 7.5 megahertz. They used the anterior triangle as a window for them, and they did another assessment after admission of the patients to the hospital with mobility tests. So they did it twice, like their anterior triangle window assessment. They have a trial of posterior window, but not on their patient. They just have it on volunteer just to compare the two images. And for sure, the posterior triangle was giving more information, but it's not applicable to a trauma patient. So they stick with their study with the anterior window. The anterior window was specified by the lower, with the lower border of the mandible and the midline of the neck, and the anterior border of the sternocleidomastoid muscle. So they utilized that part to see or take the image. They did not specify clearly where they exactly took the image on a transverse plane or on a longitudinal plane, and how did they approach the patients. It was not explained thoroughly. There was another study who also used the same anterior window, and they explain it further, like they started with the transverse window and they looked for the thyroid cartilage, and then I will explain it at the end if we can see it here. So they tried to look to the thyroid cartilage, and then from the thyroid cartilage, they tried to proceed for the cricoid cartilage, and then from the cricoid cartilage, they tried to slide it. And upon sliding just to the anterior triangle itself, they will start to see the transverse process, and this is the transverse process of C6. From that side, taking after that a longitudinal plane, they can see the C5, C6, C7 interaction. So that was explained in another study. It was not really explained in this study or how they did do the image exactly. But what they wrote, that they could visualize by this technique the vertebra from C2 to T1. They did not include any images also in their study. They did this during manual inline spine stabilization, and after finishing the study, they put back the patients on spinal collar. So the results of their study, most of their patients, almost 74% were male. The age range was from 1 to 95 years old, and the mean age was almost 23. About 39% of their population was less than 14 years. And the time from the trauma to the admission was 1 to 6 hours. Most of their patients, about 60%, were admitted in the first hour. So it's a huge percentage that they were directly admitted to the hospital, and the following image was taken. The mechanism was mainly motor vehicle crash in 64% and fall 22%. And then following after that, others like pedestrian hanging, assaults with multiple different percentage, ranging from 1 to 7 to 10%. The Glasgow scale presentation was between 6 to 11, and 24% of their patients were intubated on arrival. Most of the clinical findings that on presentation was the loss of consciousness, 83% of the patients, and focal neurological deficits, 9.8, and neck tenderness on 3.8, plus severe headache in 1.7%. So like this is the initial, most of their patients, they had an indication to proceed for a CT spine for them. So their findings, they found that the intactness of the view of the vertebral spine, the cervical spine, that means that there is no obvious fractures was observed or dislocation or in hematomas, was almost in 79% of the PoCUS and in 74% of the CT patients. So it's almost comparable to each other, it's close findings. The major things that was hugely different was in the detection of the transverse process fractures. It was only found in 2.1% of the PoCUS patient, while in 6.8% of the CT. The others, like detecting the fractures of the vertebral body, the dislocation of the vertebral body, and the fractures of the vertebral body with hematoma, and fractures with a dislocation, was almost similar between the PoCUS and the CT. And according to these results, they could detect the overall accuracy of the PoCUS as a sensitivity and negative predictive value test. They found that the diagnostic value of point-of-care ultrasound in diagnosing or detecting spinal injuries, the sensitivity is reaching 78.5% with a good confidence interval, and the negative predictive value here is 92.8. So it's considerable to this study is good sensitivity or acceptable sensitivity. It was higher in the adult patients comparable to the pediatric, as here they compared the less than 14 years to the more than 14 years, and it's very low sensitive to detect spinal cord injuries in a patients, which with 36% comparable to the more than 14 years, which reaching almost 79%. It was higher percentage, this percentage increase in the adult population after they did their second assessment with the mobilization of the unstable vertebra. So during the movement of the fractured or dislocated particles, they found that the sensitivity is reaching 100% to detect the abnormalities. What we mentioned earlier, that the diagnostic accuracy for the transverse process was lower, reaching about sensitivity of 32%. So we can see from here that the sensitivity of this PoCUS is reaching almost in the 70%, increasing with the movements of the unstable vertebrae. It's less accurate in a pediatric age group and also in detection of the transverse process. They did not comment about exactly what is the site of the vertebral body. They can detect the fractures is anterior or posterior. They did not comment about the spinous process. So all of these things, they did not comment about any ligamentous injuries, though in their paper, in their introduction, they said that it has high sensitivity detecting all of these injuries, but did not comment about these things in this study deeply. So from my view, there is multiple limitations in this study. This was a single center, though it's a tertiary care center, but it's a single center only. They utilize the anterior window where there is multiple limitations. The anterior window in another study was reported that they can only detect the anterior vertebral body parts and the lithiasis, which is the dislocation of the vertebra, but they cannot detect any parts of the transverse process, the posterior elements, or the spinous process will all not be able to be visualized on the anterior window. So they did not comment exactly if they were able to visualize these things or not. The second concern for me that it's operator dependent. So that was a radiologist. So what would be the comparison if it was an emergency physician who's performing this scan? Also the risk of bias, the one who did the ultrasound imaging and the one who did the CT and interpreted the CT findings were the same person. So there could be a huge amounts of bias. Still, could this be utilized an adjunct tool just to our clinical assessments and the plain radiograph before proceeding to the CT as an additional points? So if we go to the applicability, so if this study is relevant, it's for sure relevant to our study. We are seeing a lot of trauma patients on a regular basis, so it's relevant, and the population that they demonstrated are the same population that we are seeing. They include like from 1 year old to 95 years old. They did not specify any specific criteria. for their presentations except the clinical presentation. So they are relevant population to us. The reliability of the study and the validity are questionable, as I said, because of the operator bias, the reporter bias, and also the technique that was not explained thoroughly. So, and the limitation was not also documented in their study. What was the limitation of views when they did their study itself? So how visible is this study to be utilized and how applicable? This, I think, needs further prospective studies with a larger population and with further explanation of the methodology, so that it's going to be easily applicable to the emergency departments. So as a recommendation, this is what I think is going to be helpful. And I think after that, it's going to be like graded. If you want to do first an X-ray for the patient, plus minus doing a PoCUS or CT for the patients to help the diagnostic process and clearing the C-spine for the patients. There is another study was published almost in the same time, just because I included it because it's including images and also it's explained the methodology for the anterior window. It was done by an emergency physician. And in this study, they had like two phases. The first phase, they tried to recruit the physician training itself. They required 2 to 3 emergency physician with training for almost 3 months. They at least had to have 20 normal images and 10 abnormal images for the ultrasound before they are starting their study. And this was always interpreted after that by radiologists. Once they found that these are trained well, they started their second phase with recruiting patients. Though their sample number was low, they had only 82 like cases included in their study where they compared the CT to the ultrasound findings. I explained the technique that they use, identifying the thyroid cartilage, and then after that, the cricoid cartilage, and from the cricoid cartilage, sliding it to the anterior window. And at the site of the anterior window, they can just after that go to a longitudinal plane, and from the longitudinal plane, they can view these vertebrae. So this is the transverse process of C6. And then after that, they can identify the C6 with the C5 on top and C7 and below, and the spaces in between. So in their study, they found that the applicability of the ultrasound to identify vertebral body lithiasis was good. The sensitivity was reaching 84%, with also high negative predictive value, while the vertebral body fractures was a bit lower with a 40% in identification, but overall injuries was almost 45%. So it was in general low to identify multiple injuries aside from the lithiasis and the fractures. If they excluded the posterior column injuries completely, the sensitivity will increase. I mean, if the applicability of the ultrasound was only to detect the anterior wall injuries and the vertebral body fractures anteriorly and the lithiasis, this would increase the sensitivity of their study. So they put some images just to show how to detect. So this is the comparable of the ultrasound to the CT. So they can find here the C4, C5 lithiasis, and also here it was detected on the CT scan. The other one was fractures at the C5, and it was detected also here in the CT scan. They tried just to explain that the different views. Our study that I mentioned earlier utilized only a linear probe. This study tried to compare the anatomical view of the linear comparable to the curvilinear to show how it's going to be helpful sometimes to look to the curvilinear probe. So here you can visualize from C3 to C7 with the curvilinear comparable to only like 2 vertebral bodies going to be visualized with the linear probe, just to help for other identifications. Also, the false positive rates in the ultrasound, they have found some cases with possible step-off or lithiasis where it was only an ostrophic growth for the patients detected by the CT. So here, just to compare also the findings between the curvilinear and the linear in the identification of lithiasis. So this is my own views just to try to see how applicable is it to visualize. For me, it was a bit difficult, so I could visualize the transverse process of the C6, and on going a little bit higher, I could see the C5, but I did not take the image. And also here, just only the C6, C5, and C7 could be visualized. I tried just the linear probe itself because that was what applicable in the first study. We have just to try further just to see if the curvilinear is going to be also more helpful in identifying the vertebrae. So from my point of view, I believe that there is some limitations in this studies because the view was mentioned that it's only from C2 to C7 that can be visualized. And when we are detecting the vertebral bodies, I know that in adult patients, they have more high risk of C5, C6. So it's going to be applicable for pediatric. Unfortunately, we're having more of a C1, C2, C3 abnormalities. So the applicability in pediatric age group is going to be less helpful. Still, this tool is utilized as diagnostic tool maybe for the anterior injuries, but it's not going to be helpful for the posterior column injuries. That's my thoughts. Still, there might be an improvement in the futures for the applicability of the PoCUS in detecting spinal injuries, but I would like to hear also yours.
Thanks, Rawan. That was super interesting. Just the thought of trying to use PoCUS for C-spine injuries. So I guess I agree with you. There's certainly a lot of things lacking in the paper that I thought would have been really helpful to see. So even like, I'm glad you kind of looked it up to show us, but how do you identify, like, how do you do this scan? What are your landmarks and how do you find that out? So I guess my understanding is if you identify the cricoid tissue and then go laterally, it's assumed that's always going to be C6. That's the only landmark you have. Is that your understanding as well?
Yes, that was what was mentioned in the other paper. This is the explanation of identification of the vertebra, because in the first paper they did not explain anything about the technique. I guess because it was performed by radiologists, that's why they did not have a lot of explanation. But it was an emergency setting, so I would appreciate if there was more explanation of the technique that is used.
Yes. And so I agree, and this is radiologists doing the scan, right? So it certainly isn't something I think that is in, you know, our wheelhouse at this time as emergency physicians. Certainly will require some training. So even if we landmark to C6, my other question is, how do you know if you're on a vertebral body versus, you know, a transverse process? I feel like I'd have some difficulty identifying, and again, initial pictures of which is which. Because when the images that you show to me, that all looks like vertebral bodies, but to identify like a transverse process fracture and any of the other injuries as well, I think would be challenging. So yeah, the other thing that really bothered me was the mobility studies. So they didn't go into detail, but they must have been doing some range of motion of the neck to be able to see that mobility fragments, which I think is something that we can all say in a trauma patient. If I'm any concerned about the C-spine, you know what I mean, and they're colored, I'm certainly not going to be doing any range of motion studies to try to pick up on something on ultrasound.
Yes, so it was high risk. They did this like after the admission of the patient and decision of like any clinical management is going to be decided. They tried this just to see, but I think it carries a high risk of progressive disease and injuries itself. So
in terms of where you think first this could be helpful, low risk versus high risk, and then thinking about where you think this could be helpful, what do you think about the patients that they had in this paper?
So most of their patients, like high-risk patients, they have multiple traumas. They have, So in my view, the applicability of this is going to be in low-risk patients. That's what I want to see exactly. That's what I recommend. I mean, you want just to see if you can clear the C-spine for these patients with augmented tools without utilizing the CT, just with a radiograph and ultrasound as additional to the clinical rules. So I think this is going to be helpful. But in a high-risk patient, most of the time, because of the clinical presentation of these high-risk patients, I mean, they are having significant clinical presentation, so most of the time they will proceed for a CT brain and cervical spine. So the applicability, I believe it's going to be more on a low-risk patient rather than on a high-risk one.
Yeah, I think if there's an intervention, if we're going to be taken off a collar for some reason, certainly any kind of high-risk patient is not something I would want to do. And the GCS was like a 6 to 11, right? These are really sick patients, and some of them died. So certainly if we're looking at using something in a low-risk patient where we wouldn't want to worsen outcome, this population was certainly not that, right? They were people who should have been going right to CT regardless of what was happening, because they were quite sick. So I think too, you know, it wasn't emergency doctors doing it, right? You need extra training, and the population certainly was very high risk, where I wouldn't be putting a probe anywhere on their neck, I think, in any of these patients, give their GCS for sure. I thought it was really interesting. Thanks so much for trying and having a look at the views. Was that in a pediatric patient that you obtained those windows?
No, actually, it was in an adult patient. She was almost like 35 years old. So I tried just to identify the transverse process, as they mentioned, and then after that, the C6, C5, C7, but I still believe it's a bit difficult. I tried it only with the linear. Maybe next time I'll try it with the curvilinear just to see it's going to be maybe better alignment of the vertebra and you can assess them properly.
Yeah, no, for sure. Kyle or Peter, any other comments?
I think it's fascinating. You know, as usual, ultrasound when positive is useful. When it's negative, you need to carry on with your excellent clinical skills. This is a subject that I was interested in about 15 years ago, actually, having palpated somebody's thoracic and lumbar spine and really not finding any significant tenderness, but still because the mechanism ended up doing a PAM scan and had really horrendous fractures. And I wondered afterwards whether or not I hadn't thought of actually doing it anteriorly, because what I thought of at the time was doing it posteriorly to see if it changed the spacing to your eye between the spinous processes, and whether that would be a clue as to a fracture. But I think for the most part, my takeaway from the studies that you've looked at, certainly not ready for prime time, but for a very low risk patient, might make somewhat lower risk discharge if you were not going to do any imaging to begin with.
Yes,
Peter, yeah.
That's what I believe. It's going to be helpful in low risk patients.
Awesome. Kyle, anything to add?
No, I just agree that the two things, were just the radiologist doing the scans was one thing. How easily could we get this? And I do think the other thing is, like, it's a very cool scan, but again, that low risk versus high risk, because realistically, how is this ever going to change, I guess, our management in the high risk patient? Like, there's never going to be a time, I don't think, where you're not scanning these kind of like GCS 8, 9, 10 people. And so, and you're not going to act faster if you they're not going to go to the OR if you get a positive ultrasound scan. Like, they're still going to get a CT, maybe an MRI. So ultrasound's great too when people are quite unstable, and it's going to change their management pathway. And here, I don't think it necessarily would, but those low risk patients, absolutely. If you might not have scanned them, but then you see something that's a little concerning, and then maybe now you're imaging them. So really cool scan, but and it looks difficult.